and welcome everybody to our last day of this series. It's been such an interesting journey for all of us, and I'd like to thank all of you for staying with us for these 5 days. Since Monday, we have covered quite a bit of ground. On day 1, Moira took us through ethical decision-making, goals of care, and triage. And that's when we first encountered Ramesh and his family. And we saw that he had so many comorbidities, he had many things that were stacked against him. And we navigated the territory of how do we make decisions that are ethical and respectful and also competent. We then accompanied him on to day 2, where Dr. Sunita led us through symptom management. And that's when we saw that Ramesh was starting to deteriorate, developing symptoms. We encountered the anxieties and concerns of the family. And we had so many rich discussions about what their concerns might be and how we as healthcare providers may best address those concerns. We were also taken through different ways in which symptom control can be managed, can be done, and how to best provide excellent symptom control while ensuring that everything else is kept in balance. And as his condition worsened, when the focus shifted to symptom control, we also discovered that some very difficult conversations had to be had with the family. And on day 3, Dr. Param took us through some of that territory. And we also reviewed some of the breakpoint conversations the healthcare team would have had to have right from the beginning up until this point and beyond. And we remember his son telling us that make sure he doesn't suffer, which was a very poignant thing that he had asked us to do. We also realized that in spite of the team's best efforts, Ramesh deteriorated, and it came down to end-of-life care, which Dr. Raji took us through so beautifully yesterday. And it was a difficult session in some ways, because these are challenges that we're all being faced with right now. And it has a bearing not just in terms of our clinical competence, but on our humanity, on how we treat people when they come to us at their most vulnerable. And so yesterday's discussion was also very enriching for us. And finally, we realized that there were questions like, could he be taken home? What were the challenges? And I think we discussed what some of our concerns are with all of those different difficult scenarios that all of us are having to face, and the moral distress that sometimes accompanies these kinds of decisions. And finally, we arrived at the point where Ramesh passed away, and the family thanked the team for not letting him die alone. And we also talked a little bit about grief, and not just the grief that we might feel at an individual level, but collectively as a society at what we are experiencing together at this really challenging time. So that's been our journey so far. And taking it forward today, we're going to be talking about how do we make sense of all this distress at this time. And to take us through today's part of the journey, which is the end of this journey for us, I'm very, very pleased to introduce you to my friend and my colleague, Dr. Charu Singh, who is a very senior palliative care physician with tons of experience in teaching. She's trained as an anesthesiologist as well as in critical care. And very, very often we look to Charu to help guide us through many teaching sessions we do across the country. Accompanying her and co-facilitating with her today, of course, are Dr. Rajshri, who no longer needs any introduction and has left quite a mark on all your hearts from all the feedback I saw yesterday. And Dr. Sunita, who also doesn't need any further introduction. And so I'm going to hand over now to Charu, Dr. Rajshri, and Sunita to take us through this final leg of the journey. Thank you, Charu.
Thank you, Smriti, for your introduction. I think Dr. Rajshri is going to probably do a quick recap of yesterday's session before we go on for handling distress among Ramesh's family and healthcare professionals. So Dr. Raji. Dr. Raji.
Sure.
Dr. Raji, you're muted.
I have unmuted and I have unmuted.
Yeah.
Oh, yes.
Yeah.
Am I clear?
Right.
Okay.
Yes.
So, I mean, as Smriti has rightly pointed out, we had seen Ramesh and his family through different phases of the life trajectory. And yesterday, we sadly found that he is no more and his family is in deep distress. And we went through some tricky and challenging questions, like what can be done, what can be best, done for improving quality of life towards end of life care, and how can we excel ourselves in providing appropriate symptom control. But that story doesn't stop there. Ramesh family is in deep grief because they didn't get much time to cope with the disease and they lost the most loved member of their family. So the question was to, will we be at peace at any time in the remaining part of our life? So the question was so, it is very difficult for us to answer. And it could be as part of a normal grief reaction, and which may subside over a period of time and may reappear later in the course of life. And we need to understand whether it is part of distress, which could be more challenging, which need to be understood in little more depth. In case if we need to refer him to a more expert like psychologist or psychiatrist, we need to understand what is meant by distress and how we can explore it and how we can help a person who is in the face of distress. So I think Charu will be the best person because she was a savior last time when there was a glitch with the technology. So I think Charu will lead the session. We will chip in as and when required with the comments and your valuable and brilliant suggestions in the chat box. So over to you, Charu. Thank you. Charu?
Yeah. I'm just, is my screen visible?
Yeah.
And you can see the first slide?
Yeah.
Okay. So thank you, Smriti and Dr. Raji. I have been a left brainer, a clinician most of the time, but being in palliative care for a long time, I have seen what patients and families go through over the period of their illness and how it also affects the healthcare workers. And COVID-19 is a different ballgame altogether. It is an infection. You don't know whether an infection is going to be curable or is it going to cause death as COVID-19 has been. And when this news broke out in January, mid-January, and now we are in July. I don't know how the time has flown, but there are a lot of things that have changed. The pathophysiology has changed. The names of the illnesses have changed. The presentations have changed. So there is a lot. But in the background, certain things have actually become much worse, which is the distress in the sense of our uncomfortable feeling in our mind, which can range in a big way from one end, just sadness, to something more deeper. So we are going to go through this, and may I acknowledge my friend and colleague, Dr. Chitra Venkateswaran, who's a professor in psychiatry, who kindly allowed me to share these slides with all of you. So, okay, so these are the learning objectives. We are probably going to look at the psychosocial issues.
Charu, sorry, your screen needs to be full screen, please. It's not on full screen at the moment.
Sorry, I will just do that. I will just. Is that all right?
Not yet.
Not yet, ma'am.
You'll need to go to slideshow mode.
Ma'am,
This is the presenter view. It's okay now.
Yes, you need to take it out of presenter view, I think, Charu, and put it into slideshow.
Yeah, yes, I will do that.
Sure.
All right. Is this working?
Yes, it is.
Fine. All right. So we're going to, coming back to the psychosocial issues and the spectrum of distress that Ramesh was probably feeling, his family, and the healthcare professionals as a whole across the world have been feeling in these 6-7 months that have gone by. We are also going to look at certain ways or how to cope. We cannot learn all the skills, definitely not, but we should be able to learn how to identify people who are at risk and then be able to refer them to a relevant healthcare professional, a psychologist or a psychiatrist if necessary. And we will also look at certain complex elements of distress. So coming back to Ramesh, let's go back to when he was there with us and he expressed fear, anxiety, and perhaps other things, his family. How about starting off by sharing in the chat box what all could Ramesh and his family be feeling at that point of time? So fear and anxiety, worry, sometimes helplessness, hopelessness. It could go on to,
uncertainty, afraid, feeling lost. Good, very good, yeah.
Yes.
Abandonment. Scary, again, abandonment is coming again. Helpless.
Guilt.
Mm-hmm. Yes, I believe his son had come abroad and was feeling guilty about bringing it COVID to his family. Thank you very much. Those were very enlightening to me also, the various feelings that you put across. These are some of the things which we also as human beings go through when in our life journey. And moving on from there are certain aspects which require an expert, a psychiatrist, like clinical anxiety or clinical depression, rather than using depression as a loose word for sadness. I would call it clinical depression. So we are familiar with some of these things that both Ramesh and his family could have gone through, and perhaps the family is still going through some of those. So the people who are at risk are more likely to go through these levels of distress, and also relatives of those. And as a daughter who has parents who are above 80, I keep worrying about my parents, even though they don't have many comorbidities. But will there be beds available? At this point of time, I am in the National Capital Region, and the number of beds that are available are at an acute shortage, and the charges that private hospitals are asking are beyond affordability for even people in the upper middle class families. And healthcare workers and carers are some people we never focus on. They require care too. And we had an argument over WhatsApp with a lady who said N95 mask is the best thing when you want to go and buy vegetables from the market. And I was like, excuse me, you're taking away all the personal protective equipment that the doctors need, and the doctors, nurses, ward boys, ward ladies, technicians need in the hospital. And she very vehemently said, I'm the wife of a doctor. And I had to then give her my list of qualifications, and there was deafening silence after that. So this slide, I think, is very relevant for Ramesh's family. We do know that when people with COVID start deteriorating, they go downhill very fast, maybe perhaps about 48 hours or so. So there is, the only thing that we may be able to provide is good symptom relief and prevention of suffering. But what about the rest of the family after you've lost Ramesh? So as you can see from in the top that you have a healthy person who gradually goes on to become ill. And on the left extreme, you can see that there are sections which are related to a person's emotion, their thought process, cognition, their normal work pattern, sleep pattern, eating pattern, work pattern, and also their ability to cope. And maybe I will just use an example here randomly, that a healthy person would probably have a normal sleep pattern, but someone who's adjusting and reacting to what suddenly happened, they have trouble sleeping in the night, and perhaps nightmares and intrusive thoughts. Someone who is more distressed would probably not get sleep at all. And a person who is ill may perhaps want to sleep all the time so that they don't need to think. So it can happen. So the changes happen at the cognitive level, emotional level, functional level, and also coping. A person who's healthy may cope in a very positive way, but someone who is ill may actually start substance abuse. So these are some of, this is something that we need to understand, that a sudden change doesn't happen. It's a gradual thing, and we should be able to recognize people who are at which point using the cues. These slides are available to you in your resources, so you can go back and look at them. They're slightly complicated. So since we are talking about psychological distress, and distress is a very broad term, where do you think distress manifests? I'd be very happy if you could add in the chat, and Sunita could share it with us. Where do you think psychological distress manifests in a person?
Please come forward with your suggestions in the chat box.
I've heard a lot about this group. They're very senior people, very involved people, and I came in hoping that I'm going to learn lots of things from you, share and learn and go back from here. So, Dr. Raji or Sunita?
Yeah, so we've got some coming.
Yeah.
So it affects the behavior, it affects the health, it affects the home, the family. So Dr. Manoj just put body and mind. So the question was not clear. So we are asking in which all aspects, which all domains does the the distress manifest? So that was the question. Ma'am, there's a comment about the sound not being clear. So
I have Yeah, I have been told once or twice. So you can hear me now? No.
Yeah, it's better now. Yeah.
Okay.
So anhedonia, lethargy in relationships, it can affect the relationships. Then a person would want to be alone. It affects the mood. It affects the workplace. So these are the comments coming. So a person has put physical, mental, and social state.
Yes, I'm glad. Thank you so much. I think you have summarized most of these things that people have manifestations in fatigue, family relationships. So it is emotional, physical, behavioral. These are some common areas that distress can manifest as. There are also certain things that I'd like to bring to your notice, that some people have pre-existing conditions, and in times of psychological distress, these conditions can actually get worse. So we need to keep an eye out for these too. Perhaps we do know with stress, blood pressure goes up, diabetic control goes off the scale. But what is most important for us are the red flag signs. People who are agitated, confused, are on substance abuse, are having hallucinations, delusions, or suicidal ideation. These people, if you can identify, they need more help than we would be able to offer. And we need to refer them to a specialist, a psychologist, or a psychiatrist, because these can end up in a very negative way, adding to the distress of the whole family. So since we've been talking about distress, and we've talked about where all distress manifests, we also need then certain tools, screening tools, where we are able to identify who is at distress and what is the cause of their distress. So this distress thermometer is normally was used for cancer, by National Cancer Center, but has also been, there's been research, and we and my colleagues have used it for patients with COPD, whether a chronic illness would cause similar features in patients with COPD. So it is just like your numerical, when you're rating your pain, 0 is no distress, and 10 out of 10 is the extreme distress that a person can ever imagine. And if the distress is 4 and above, that's an indication for us that we probably need to refer this person to a specialist. And as you can see, the distress thermometer on the right side has various sections, things like practical problems, family problems, emotional problems, spiritual or religious concerns, and physical problems which can cause distress. Uncontrolled pain, for example, can cause distress. Fatigue, which we don't normally focus on, can cause physical distress. And you have already mentioned many other problems. Yes, some of the family problems and changes in relationship can also add to this. So this thermometer is ideally to be used for the family, and has to be done periodically. But then how do we explore where the distress is coming and how is it manifesting? So this is another screening tool, the nurse protocol, and the naming the emotion. You seem to be angry. You seem to be very upset. Understanding it. I can imagine how stressful this could be, or I cannot even begin to contemplate how difficult this is, because I'm not in your shoes. Respecting the patient and caregiver, because what they are experiencing and where they're coming from can be completely different, and perhaps we would also like to be treated in the same manner. So this is what we need to offer our Ramesh and his family. Support. Actually, instead of being able to offer support, we should help the family to look for support give suggestions like, when there has been distress in your past, when you have faced a difficult situation, what has helped you? Does praying help you? Is there a friend that you can talk to who can help, or is there any activity that can help you look after yourself? So giving these suggestions can help them to think. And I have had some people reminding me about these to find where I can seek support and self-care from. And exploring the emotion further. This is very important because as we are seeing that, when this whole epidemic started, people were saying that all the temples, mosques, and churches are empty because all the gods are wearing white coats and are in the hospital. And suddenly in June, July, when people, doctors and healthcare workers are going to a family and trying to identify contacts to quarantine them, they are being not dealt with respect. And the concern may actually be fear. The fear may be manifesting as anger. So we have heard the people saying, don't come here at all because you're getting COVID. A doctor was not allowed into his society, forget about his flat. He was not allowed by the residents because of fear. So always asking the question behind the anger and exploring it seems to be useful. Let's move on. Coming to healthcare workers. It is very important because we have been hearing stories. We heard that the Italy's prime minister went on national television and was crying. I've seen videos from Spain where doctors are crying and saying that I am feeling helpless, and something which shocked most of us and which was a little more personal. Was a doctor who was was 49 years old, head of emergency services. She suffered from COVID-19, recovered, came back, and after a couple of weeks spoke to her family and died of self-inflicted wounds, as the press reported. So perhaps she was going through a lot of distress, which went unnoticed. And that is something that we need to focus on today. So while we're talking about the distress that Ramesh's family is now going through, we also need to remember that this is as much applicable to the healthcare workers also. How about your telling me what are the things that you seem to be facing, those who are looking after COVID patients or who are actively going for work? What kind of issues are you facing? So while I have people typing out their answers in the chat box, this photograph, I think, is very evident of the stigma associated with Corona lived. And it is not just in the hospital. Dr. Chitra herself was sharing with me that when she comes back from work, even though she's a psychiatrist and is not coming directly in contact with COVID patients, when she enters the lift, the other people who are staying in her apartment block, they smile, greet her, but they don't enter the lift with her. So this is happening among educated people also because of fear. Sunita, any inputs in the chat box?
Someone has put burnout, and one of the doctors has commented that few of my pediatric residents are victims of COVID themselves, but losing their fathers to COVID. So, yeah. And then the report of sudden death after recovery from COVID is coming.
Mm-hmm. So yes, so there can be a lot of distress. So we were talking about certain emotions which we go through in our normal daily lives, like sadness, hopelessness, and we then spoke about certain clinical conditions like anxiety and clinical depression. But there are these terms, moral distress, compassion fatigue, and burnout. And someone has already brought out the definition of burnout. Could you elaborate for the rest of us what you understand by burnout? I'm happy to have inputs on anything out of these, the moral distress, the compassion, fatigue, or burnout.
Dr. Tirumala Rao is put in about burnout. So do you want to elaborate on that, please? Yeah, somebody, Manoj just put in withdrawal, exhaustion, and disillusionment. Fear of carrying infection home, withdrawal, exhaustion, and disillusionment. Prolonged stress is what he's put in.
Yes, thank you very much for those things.
Physical exhaustion. And think about your experiences, and have you had situations not related to COVID, even in your clinical practice? Have you had situations where you felt like that? Can you identify with what what we're discussing now? Moira has put in, hard to see parents dying of COVID when you're trying to care for patients. Yeah, it's very true.
Yes. We will always be in that dilemma. Our duty as healthcare professionals to be there for our patients, despite knowing that we ourselves are facing the risk of the illness and bringing it home to our parents. So
Dr. Manoj just put, when my sister was going through CML, and it's very, very difficult, and thanks for sharing that, Dr. Manoj. So when it comes to personally to us, it's all the more difficult. A doctor I know said he develops palpitations every time a death is reported from his ICU.
Yes.
Yeah.
Thank you so much for
sharing.
Yes, thank you so much for sharing your feelings and sentiments with us, because I can also relate very well to this. I'm working in palliative care, and for me, death is a reality and something which I am not really worried about. But if I ever talk to my family members about death, they're like, why do you keep talking about this? And if you've had a bad experience, any other event which comes in your life can bring back all that distress right back in your memories and in your life as a whole. And so if you look at certain of these terminologies, moral distress is normally related to a situation where we are bound by certain ethical rules, or the Hippocratic oath for doctors, where we say we shall do no harm and hopefully try to save lives, if not, at least provide care. And if we are unable to do that because of certain factors, it does cause an emotional or a moral distress, which can be confused very much with other conditions like depression, with which we are more familiar. But we need to understand that this distress is because of our inability to provide the care which is why we join healthcare and the oath that we had taken to help our patients. Compassion fatigue. I was on 1st July was Doctor's Day, and the clip, I can't help but tell you this, that there was a clip from the movie Patch Adams, where Robin Williams is playing the doctor. He says, indifference is the biggest illness. Doctors and nurses are asked to be objective, not involved emotionally, so that we can take decisions rationally. But that is not really possible. I had seen it. But when we look after people, we are also a part of society, and we give a part of ourselves to our patients. And if we don't focus on restoring ourselves, then we may reach a situation where we end up with compassion fatigue. There is, and it's very important for me to remind you here that I recently also received a message that which says that your compassion is incomplete if it does not include yourself. So you have to take it sometimes easy on yourself and not push yourself to limits beyond yourself. And burnout, as people have said, are the stressors which arise from our workplace. In palliative care, are not getting beds, are not getting nurses because there's a shortage, and they're better utilized in cardiology or oncology, and things like that can really add to our stresses. And so thank you to Manoj for putting some of these things out for us, that burnout can manifest as emotional exhaustion, a sense of low personal accomplishment. I don't feel involved with my patients as much as I used to. A sense of depersonalization, again, becoming not intentionally, unintentionally becoming depersonalized and not looking at your patients as human beings, but again, as a diagnosis. So this is very important, and why I also want to talk about this is, again, because this gets these three things: emotional exhaustion, low personal accomplishment, and depersonalization or dissociation can be confused with clinical depression. So we need to be aware of these concepts. I don't know in depth about these various terms that I have just told you, despite being in this particular profession for many years. But my only intention is to introduce them to you today, so that you're aware the next time that when you're facing distress, you also focus on these 3 or 4 things that affect our lives. So going back to the healthcare workers this time, the nurse breaks down and says, whatever I do doesn't seem to help anyone. My life, my work, my studies have been worthless. Or what do I do? What do I do if I end up taking the infection at home to my parents? And financial issues I should bring up here, because I've heard that the footfall in hospitals is falling, and there are doctors in Karnataka who have not got their pay for the past 16 months, but are turning up every day for work. So these are some of the situations which the nurses could be facing, as other healthcare professionals. What are some of the things that you are facing in your workplace? Could you share those with us, please?
There were some comments that interesting, very, very interesting discussion that's going on in the chat while you were
please,
ma'am. So probably I should just read the whole thing. So Sonali has put in, I went through a phase where I was emotionally saturated and avoided picking up the phone when there were people calling for help and advice. Has anyone experienced something like this? It's really, really interesting, isn't it? How,
I have.
Yes. I think we all have, isn't it?
Yeah, we all have at some point, yes.
Who is going to help the person who helps others, basically, like Deepak had initially put in a very interesting comment of that I'd missed, so I'll just go back there. It's suggestion about putting the, often managing distress is sometimes just leaving the door open and letting people know that you are available to talk if and when distressed person feels like this. So they may want to talk at that moment. They may not want to talk in that moment, but knowing that someone is available when they need it and can be of great help. So connecting these two together. So you say that somebody can talk to us, and then you yourself are distressed and you can't answer the question. So yeah, it's quite interesting. So coming down, and again, Deepak has added that medical residency in India is designed to stress out the resident out, but very often it's not the work, but a culture of bullying that exists in medicine. Patient loads and hard work cannot be avoided in training, but the hard hierarchies are sometimes a source of stress for themselves. Yeah.
That is very true. And I'm picking up on the last word first, the hierarchy. The hierarchy which exists between doctors and nurses can really add to the stress and burnout for our nursing staff. And I personally have learned a lot from my nursing staff. And Sunita and I have worked together, and she knows that there have been times when I have gone and written prescriptions, and I've got a call from my nursing staff saying that, "Madam, this dilution is probably not correct," and I've needed to go back and fix it. So yes, we don't respect the hierarchy is very tough to handle. And yes, going back also to a statement that someone said that, yes, that somebody is there if I want to talk. That sometimes is very important. We cannot fix every problem. But so I heard someone say that when you're in distress, a true friend will pour a cup of coffee, pull up a chair, and sit down with you to listen. So yes, so we can perhaps help each other. And I think I have seen, since I worked in critical care, I have noticed that some senior nurses are looking out for the new nurses who have joined in the critical care and are seeing things going from bad to worse, and they keep an eye out on them and have a debriefing, a conversation, or identifying issues before they go out of hand. So yes, even though our system is very hierarchical, perhaps we should be the change. And so apart from the distress, the moral distress, the compassion fatigue, the burnout, there is also spiritual distress, which we don't talk about much. Can I request Dr. Rajshri or Sunita to pitch in? Because for me, there are multiple levels here of spirituality, which can be complex to deal with. Dr. Rajshri? Sunita? Well,
is something which many of us get confused. Sorry, Sunita, would you like to comment? Hello?
Let's put a comment in the chat that I think we should know what is a spirituality to understand others' spirituality.
Yeah.
So
Rajit, yeah, I can hear you. Sorry. Can you just repeat it?
No. I just started telling. I mean, then I heard some noise, so I just interrupt. I mean, I paused. Did anyone else make a comment? Sunita or Stella, I mean,
I think Sunita is having some difficulty with her audio, Raji. So please finish.
I actually commented one, Rajichi, that when we are working, usually the seniors, they don't give ear to us. It's whenever we are undergoing some problem, especially now in the COVID time, especially the juniors are facing a lot of problems, and they actually wanted to talk to the seniors, maybe it's doctors or the senior nurses, or but many times it doesn't happen, and that is where they find so much of distress because they cannot share their problems.
yes, exactly, exactly. That is what, many suggestions in the chat box have pointed, like the hypocrisy or the so-called bureaucracy happening in our medical field, and many times the overburdened junior residents or the junior level professionals may not get, already they are overburdened with the workload, and they will not get enough time to share their concerns. It's very difficult for the junior professionals, I understand. uh, uh, Charu, should I comment about spirituality?
Yes, why not, Dr. Ruchi?
The thing is that spirituality is something like a universal aspect of human nature, and many people give different meaning to spirituality. And when I tend to ask spiritual questions, most of the patients or the family caregivers immediately attribute spiritualities to theistic beliefs. But spirituality is not directly related to religion or theistic beliefs, but those kinds of beliefs and the practices are means of attaining spiritual contentment. That is what I have learned from my experience. So it is so private, like has got many taboos, and it is so subjective and unique for each person. And it's a very sensitive aspect of our domain, and like it's mysterious as it is shown on the slide. And the spiritual development, it happens throughout our life cycle. It is not like a typical pain ladder, where we can stop up to what, we reach up to a particular level, okay, you attain that kind of pain relief or something like that. So spirituality is, gradually or slowly evolving process throughout our life journey. So it has got, patient connections as well, like affirmation, forgiveness, and reconciliation, giving meaning and determinism. And it is also has got some relationship with God and fatalism. At the same time, when it is concerned to professionals, it may be linked to lack of clarity and inability to prioritize things. And it may be related to poor skills and our own sets of beliefs. And for a society, it is attributed to taboos and the societal beliefs, and like opportunity for sharing and community support. So we cannot find, this is spirituality. You cannot show something like that. It is so widespread and encompassing all the physical and the psychological and the social domains. And and many times, a kind of, you have to ask something different to the patient, how you find, how were you able to achieve kind of connectedness or peace in your life trajectory. In many people it could be related to theistic or religious practices. But for many other people it may not be like that. For me, though I am a believer, and my spirituality is totally different from that of a pious person. I find meaning, or I find extreme solace and comfort when I am left alone, probably in the beaches or in a hilltop where I am alone and let to think aloud. That kind of, so each one of you can find out what gives you more meaning and what gives you more strength when you come across with a life crisis. So probably that kind of questioning might help. So you might have gone through different crises during your life trajectory. So just take a break and think, and what has given you that kind of strength to tide over that crisis. So probably from such questions, out of such questions, we may be able to identify, not exactly identify, you may be able to peep the spiritual domain of the person. It may not be easily achievable in one sitting, but we have to continue that. In COVID-19, we may not be able to explore in detail because the disease trajectory runs quickly, but still that kind of question might help at least to the patient's family members, how they find it, the connection inward, your own belief system, your own strengths, and your own thoughts, that is connecting inward. And how you connect it outwards means how you connect to the nature, the society, the people around you, and connecting upward. It could be the supreme power, it may be the god, or it could be some scientific principles, it could be some other some other agent or some power which gives you some courage or boldness. So it is like connecting inward, outward, and connecting upwards. So it is a connectedness all around. This is what I have understood about spirituality, and I'm sorry that I am not able to give you a concrete picture of spirituality. It is always diffuse, and it is always better to ask what had given you the peace of mind and strength to tide over a particular life crisis. Is it okay, Charu?
Yes, Dr. Rashi, thank you so much. I just quickly want to, I think we're running short of time, but so I quickly want to say that I am comfortable with my emotions and I can identify my emotions. So I don't have much difficulty in talking to patients or family members about their emotions. But spirituality, maybe at a broader level, would mean for me something that gives meaning to my life, and it changes sometimes from time to time. The only thing that we need to remember is that what works for us may not work for the other person, and we are there only for guidance rather than prescribing things for them here. So we still, I think, have about 5-10 minutes to go. So so going back to our narrative, lockdown has closed a long time back, and the number of patients shot up drastically. People were questioning the government whether they were right in doing the lockdown because it brought a huge economic crisis across the world. So there have been a lot of losses for people. When when Ramesh passed away, the sons lost their father. Perhaps they lost the advisor they had in their lives when they had difficult decisions to make. Perhaps they lost someone who's the breadwinner of the family. And all these losses can produce grief. And the grief in this situation is very complicated because things can change very suddenly and you don't have time to adapt. But because of this loss, grief, and I don't think there is any person who has been left untouched. Recently used the word syndemic, that there are losses happening at multiple levels, not just family members, but at many levels, that it's a humanitarian crisis and causes trauma at a big level. And I think a lot of people are predicting that by the end of this pandemic, we will be dealing with a lot of post-traumatic stress disorder. I'm going to go ahead just because of the shortage of time. There are these two algorithms that are present in your ebook resources, which you can use as guidance. You can see the green to the red arrow pointing out how you can intervene, how you can identify where a person is, how much distress they have, and follow the arrows and use that as an intervention. There is also another algorithm on page 41, which tells you how to identify distress, how to identify grief, how to rule out depression, assess suicide. So these algorithms are very easy and simple to follow. And I have started using these algorithms after my friends in PalliCovid Kerala put this ebook out. So a very quick input from everyone. How do you think you can support someone in distress? Sunita? I think probably Sunita's audio is not working.
But by listening to him,
Yeah, there you are.
Yeah. Sorry, ma'am, I was lost in between. Sorry. So we've got a few comments coming. So by listening to him or her, so how do you support? So sometimes being present for the person makes a great help. We have to do our part of work sincerely and efficiently, and effective communication, giving time to the person to talk. Listening or letting them know there is someone who is there for them.
Yeah. A warm hug was meaningful.
Yes, a warm hug is very meaningful. And like I said, seniors watching out for the juniors, when they identify any distress in themselves, going to the seniors to talk about it, or after a very heavy shift duty in extreme heat, wearing the PPE, when your shift ends, you just take a break of 10 minutes, and the doctor can say, I'm sorry, I was stressed, and so I yelled at you. I didn't really mean it. He can say this to the nurse. And we need to remember that at our own individual level also, there are things that we may do to prevent reaching that level of distress. So like ventilation and validation.
Charu, there is an important comment in the chat box. Dr. Sheetal has mentioned avoiding reading media coverage. Definitely it adds to distress.
Avoiding media coverage.
Yes, media coverage. Mm-hmm. You know, each time he opens a news channel, no, it's given the breaking news. Huh?
Yes.
It's reported. Yeah, that's
completely. All. Thank you so much. I relate with it so intensely that I stopped watching TV for a very long time, till suddenly one day I realized that the number of patients of COVID in India have crossed 9 lakh. Yeah. I'd left it somewhere at 80,000. And so that was my coping technique, even though sitting at home taking a break. But yes, and sometimes focusing on the problem and being a support for each other are very useful. So this is again about taking care of yourself and to avoid burnout, to be able to identify a situation like burnout and not confuse it with clinical depression, or going to someone for help. There is no weakness in accepting that we are human beings and we feel and we hurt. So working in a good team, having a good bond, like Dr. Rajshri said, with yourself, with your team, with your society, with your family. And yes, having a blend of work life. I don't know whether that works for many people, because for my husband, his way of coping is going deeper into work. And I have to keep reminding him, nobody is going to remember what great a presentation you did when it's your last hours, except for me and your son who's going to be present next year. So yes, taking care of ourselves is of primary importance. Yes, Sunita.
So there's some comments earlier on. I think when I was logged off, I lost all the chat. But I remember Deepak commenting about, like taking the juniors out for a drink or a meal outside, or spending some, time outside the workplace, basically. So even when I was a trainee in UK, that's one thing they're always. It's important in Western culture to have a work-life balance. It's so important for them. So basically, after each of our posting ends, we all have a meal outside, and obviously drinks outside, and it's like a social gathering outside the work, and that they do regularly there. I think that's something that we need to practice here also, because we should have a social life outside the work.
That's very true. And can I just thank you, Deepak, for bringing this up for me, because I remember when I was doing my MD in anesthesiology, I was, as residents, overworked. I have done shifts for 36 hours. And while I was studying, there was we used to have books coming out with recent advances, and they had compared anesthesiologists with pilots, saying that you need that amount of vigilance. An anesthesiologist needs that amount of vigilance that a pilot needs. And pilots have rostering 8 hours, and they you have a replacement pilot in the plane, but that does not somehow apply to resident doctors. And I have had situations where I've used held up the induction agent for inducing anesthesia and wondering, what is this and what am I supposed to do? Because the overwork has completely shut off my mind. And that was very difficult. And I believe there was a recent issue where one of the pilots was found to have alcohol in his breath, and he was derostered, and another pilot was called in. By that time, the main pilot, his 8 hours were over. He was not even flying, but he was also sent home, and another pilot found to replace him. And I guess that is something which is very important. So I don't think I need to summarize much, because a lot of input has already come in from the chat box. Thank you so much for being patient with me. And thank you also for pointing out so many things which I have learned today from all of you. Thank you. Smriti?
Yes, thank you.
Handing over to you. Yeah.
Thank you, Charu. I'll just wait for the screen share to stop. And
that I need to do it from here. Thank you for reminding me.
Thank you.
I'm still struggling.
So we actually have we have 15 minutes. So I'd like to invite everybody to share their comments, their observations. If you have a situation that you've been dealing with that you think you can bring to this forum, there are some excellent people here to help you navigate that territory. So please do share. And if any of you would like to speak and speak audibly, then please raise your hand. We will unmute you, and we're happy to hear from you. So Dr. Raji, Sunita, Moira, may I also invite you into this discussion? It's been a very, very, I don't know, it's been such an interesting week for us, watching this group evolve and grow with us. And initially, actually, this is the highest number of participants we've had on these sessions. And so we were a little bit worried about, how we're going to manage it. But I think it's been so refreshing.
Rewarding.
Yeah, and very rewarding. That's the right word. So please do go ahead and share any of your experiences with us. We're happy to take feedback. If something stood out for you, we're happy to hear it. If something that we can do better, please go ahead and share. And of course, if you have a story to tell us, please tell us that.
Yeah, and I think most of us will also be open to any of your inputs, which we have shared with you or tried to tell you how to use morphine, but if it is not available in your area, we'd like to hear those issues also, so that there is a network and we can facilitate this through various ends. And if this has been an appetizer this week, there are other courses that you could do too. Yes.
Yes, I just saw that.
I'm going to mute myself.
No.
Perhaps I'll come in if that's okay.
Yes, please, Moira, come.
It's been wonderful listening to the discussions. Thank you, Charu, Sunita, and everyone else for their comments, Raji. And I've loved seeing the variety of responses. And I think what we're getting to grips with in this session is that distress is a very broad concept and brings in so many factors, but it's a helpful concept to start with, because labeling and putting into boxes can be unhelpful. What I am seeing though on the chat was just still some confusion about the spiritual aspects. Maybe just if I can just say a word or two. This is about recognizing the things in us that help us to connect, that give us meaning, that give us hope. And those can be our grandchildren. They can be, you know, the fact that we're doing a job that is worthwhile. They can be many different things, but I wouldn't shy away from it. I know we don't want to judge or to put labels on people, but that's not what we're doing. We're saying to people, including ourselves, what restores you? What supports you? Where do you go to when you're having a really tough day? If things don't make sense, how do you make sense of them? And some people will be very clear on those things. Some will say, actually, I don't know. And that's when they might need some help. But I would suggest to you that you do something just now. And that is that you write something that restores you physically, socially, psychologically, and spiritually. Write actually something concrete down. So it might say, I want to hug my family members and I want to eat some chocolate or some kulfi. I want to watch a beautiful sunrise and I want to engage in my faith practices. That would be those are all things I would love. That's why I've told you. But I would ask you to write those things down and to do them. So to make sure you are continually giving yourself your own prescription for holistic health, and don't forget the spiritual component, and don't forget that beauty is one way that we nurture our spiritual souls. And that's my just little tips to give you, and how lovely it's been to work with you all week.
I'd also like to share that there are some very helpful prompts that can be used to explore spiritual distress in people. And one of the things that we have found useful in our practice is actually the Oxford Spiritual Assessment Tool, which looks at spirituality along 4 quadrants: connection, meaning, hope. And there are associated, and one more, there's associated questions with it that can be woven into a conversation with your patients. It's not like a checklist questionnaire. So that is something that we have found quite useful in our practice. And what's nice is that it also sort of doubles up as a rapport building tool. So so that's a great, I mean, that's something that we use quite often. And if anybody wants to look it up, it's available on the Oxford textbook of palliative care.
Smriti,
yes.
I would like to read a post by Param in the chat box that found it interesting. You might have gone through that. Excellent comments about respecting the varied choices of spiritual connections of people. One thing I would add is there may be people who don't believe in anything, religious or other form. They just live life as it comes and they don't feel the need to give any meaning to life. They may sound flippant, but that too needs to be understood and accepted. So that also an important point, Smriti, because I mean, we come across with, particularly in, certain groups or types of people, if you ask them, they may tell you that, I mean, there is nothing like that. Meaning in life? No. What is there? So
I did try to answer that one, Raji, in the chat. I think we just shouldn't get too caught up with terminology. Yeah. We just say to people things like where do you go to when life is difficult? When you're having a hard day, what things help you? You know, if someone has gone through something difficult in your family, how do you make sense of it? And actually, everybody has some construct that they use. That's part of life. Sometimes those who don't know their construct, they struggle when life gets hard. So I think it's a journey we're on, and that journey allows everyone in as part of it. But just like we learn to communicate, just like we learn to control pain, we also have to learn to nurture our spiritual and psychological selves in whatever way makes sense for us.
Absolutely. And in fact, that's also where, you know, the domain of connection comes. It could just be, you know, I mean, one of the questions there is, how have you, what helped you get through difficult times in the past?
That is what.
Or it could be, who are the people or communities you look to for support? So, you know, connection could be very well on that level as well. Yeah.
Can I add a comment here? We have spoken about compassion, I'm sure, throughout these 5 days, and being non-judgmental is being part of being compassionate. So to whomever, whatever fits them, to be accepting, I think, is very important to remember. I don't feel like leaving this group.
So, sorry, Charu, go ahead. You were saying.
No, I was just saying that so many things I've learned today that I would like the session to go on, I guess. So.
We're almost at the end of our time together. So I'm just going to take a few minutes to wrap up. And I'd like, again, to thank every one of you who have come, attended, participated, listened, shared your experiences, shared your concerns. It's not always easy to talk in a professional forum about things that you have found distressing, but some of you have opened up so much to us, and we have learned a lot from that. And more than anything else, I think what's important for us to remember also is that we're all connected, we're a community. We've met here on a virtual platform, but I think we've all been, we've really, I think, formed a connection. And I'd like to thank every single one of our faculty members who have led us through these sessions this week. Moira, Raji, Sunita, Charu, Param, I mean, the others were not here. And Sunita, of course, she's here still. And Sister Stella and everybody else who also added to the conversations. It has been a really interesting and encouraging journey for us through this PalliCovid ECHO sessions. We started with small groups, mostly palliative care people. Today, we're seeing people for the first time who've come in. Some of you have probably, this has been your first encounter with palliative care. I hope a lot of it has resonated with you. And all of us are always accessible. It's been a 5-day session, but this is not where it ends. So please feel free to reach out. We're always available and approachable. And do send in your feedback. We'd be very, very grateful to learn how we can improve the sessions. And if you, I mean, it'll be great if you could do the post-test as well. So with that, I'd like to just, Sunita, I mean, you've been in this journey right from the start. So I'd like to hear, you know, what you've said, what you've had to say and share with the group.
I just want correction. It's not a post-test; it's a post-evaluation. So, and I want to correct it because just to make sure everybody fills it in. Because please do fill the feedback, and I myself personally has made it mandatory that unless you fill the feedback, and you won't get a certificate. But the thing is, it's only for us to know that how we are doing, because feedback is the most important thing for us to improve the courses. And to talk about the whole session, so like Smriti said, I have been there right from the beginning and has been going through the it's 11th season, 11th batch I think we are doing. And I think, as Priti said, again, this is the maximum number of participants that we've had. So, and I think about 200 registered. So, so we were quite a bit anxious of how this is going to turn out, because obviously, we need to make sure everybody is involved in the session, and also to make sure everybody gets something from it, and we also learn. But I think it has gone very well. The group has been really good. It has been an interactive session. We learn from each other, and it's even though we do it like so many times, we still think that we're doing it the first time, and we are learning things, and we are making changes to our presentation depending on the feedback that we get. So if I think one of the doctors who has attended today has attended the first session. Is she still there, Dr. Praveena Raman? I saw her. I think she's there for the, so she probably will know the difference between how we have done in the first session and how it has changed. So I think it's been a wonderful experience, and probably the one positive thing that has come out of the whole pandemic, which has been a source of distress to all of us, is that we are making new friends and trying to sort of advocate our specialty. So thank you very much. Thanks to PalliCovid India for giving us all this opportunity. Thank you.
Oh no, the privilege is ours. And just to point out what Deepak has said, the post evaluation is different from the poll that comes up, and it's sent as a link. So there's a distinction between the poll that comes up and feedback. So we are at the end of our time. Dr. Raji, Moira, any last words before we wrap up?
Smriti, I have talked a lot over these years. So I think
we never get we never get to speak to all of you.
I wish everyone well. I think this is a time when we stand together, is it not? This is a time for, yes, physical distancing, but social togetherness, global solidarity, and we stand together to look at this new pandemic, but also to take the opportunity to see how we can integrate holistic care, palliative care in our communities. And I look forward to all of you being part of that way forward. Thank you.
Thank you, Moira. No better way to end this session. Thank you. All right, everyone. Please stay on, fill in the poll, fill in the feedback, and we hope to cross paths with you again sometime.